No worries. But that one also not connected to anything? Yeah, this one is.
Hi,
This is mine.
good evening, everybody. Good afternoon, rather. Sorry. We are having slight technical problem with our internet connection. So I would like you to bear with us a short while. I'll take you through the housekeeping slides first, and then what we'll do is we'll bring the speakers for the grand rounds on board. Okay. So today's cardiology grand rounds will be on controversies in lipid management, and the presenter is Dr. Jayamala, and panelists are Dr. S.P. Chan, Dr. Kanan, and Dr. Yong Fiman. Okay, now we would like you to use Slido as the interactive Q&A. So please have your device with Slido or laptop and open slido.com and then enter the code 41509 to participate in the discussions. All right. So the Q&A will be at the end of everything. Okay, so we are going to use Slido for interactive Q&A. Though if you are on the Facebook, like Stanley says hi, hi Stanley. Although Stanley, that's not your real name. I know your real name. You're not telling you. A lot of pseudonyms on the Docs Facebook group. Okay. Anyway, if audio is okay, let us know. We just shifted to another room because we had very unstable internet connection in the other one. So I hope please bear with us in case there are problems. It seems to be more stable in this room. All right. Now we will be displaying a QR code. Hopefully, I'll remember this time. We won't. We forgot the last run, but we will definitely remember this time to show the QR code, and so you can claim your point. But it will only be displayed at the end of the session. All right. So the code will be displayed in this blank space in this slide. So what I'm going to do now is bring my colleagues on board, and yeah, that's Dr. Jayamala, Dr. Kanan.
Hello.
Muted, not yet. And Dr. S.P. Chan. And then last but not least, Dr. Yong Fiman. Okay. And I'm going to remove myself from the stream. And then I'll let the guys take over, and I'll shift the slide share to Dr. Jayamala's slides. Okay.
Thank you very much, Ellen. A very good afternoon to all of you. And thank you very much for joining us in our SJMC Cardiology Grand Rounds. This is our number 4th Grand Round, and I sincerely hope that you all have been enjoying yourself and learning something. We are, of course, very proud to be the best hospital of the year in Asia Pacific for the 2020. The topic today is controversies in lipid management. And as Dr. Ellen has said, I have Dr. Chan, Dr. Yong Fiman, and Dr. Kanan here with me. A very quick reminder that in 2017, the Malaysian Clinical Practice Guidelines on the Management of Dyslipidemia has been produced. It is available at the website as shown below. And we encourage that doctors categorize your patients as to whether they are very high CV risk, if they already have established cardiovascular disease, diabetes with proteinuria, or with a major risk factors such as smoking, hypertension, or dyslipidemia, or if they have CKD with GFR being less than 30. And these are the target LDL levels to aim for. High CV risk are those with diabetes without target organ damage, CKD with a GFR of 30 to 60, or if your 10-year CVD risk is more than 20%, and that is your target. For intermediate and low risk, we encourage that you use your Framingham risk score. If your intermediate risk, if your 10-year risk is 10 to 20%, and low risk, if the 10-year risk score is less than 10%. And this is Framingham risk score that is present in the CPG guidelines, and there's one for women and there's one for men. And by that, using this category, you will know what your target LDL level is. Moving on to our first case. Our first case is a 55-year-old man who is admitted with an acute coronary syndrome. He is investigated and found to have a high-grade LED lesion, which is then stented. His other arteries are normal. He's a non-smoker, no previous medical history or family history of note. Our blood pressure is 120/80. During episodes of chest pain, there was ST segment depression, but once the pain was resolved, the ECG normalized. Echocardiogram was normal LV function. These were his blood tests at admission. Total cholesterol 4.7, HDL 1.3, LDL 3, TG 1.6, sugar as shown, and the liver enzymes. And these were his medications at discharge. So the first question is directed to Dr. Kannan. Does this gentleman need a statin since his LDL cholesterol is only 3 millimoles?
This gentleman certainly needs statins. He has got established coronary artery disease, and therefore he belongs to the very high risk category. The previous guidelines have advised that in this group of patients, we keep the LDL cholesterol to less than 1.8. But if you look at the latest European guidelines, which came at the end of 2019, they've advised that the LDL cholesterol be reduced to 1.4 millimoles. And they gave a level of evidence of 1A for this, which is very strong. The recommendations are based on the results of the Improve It, Fourier, and Odyssey trial results. So he certainly needs statins, and we need to bring his LDL cholesterol down to below between 1.4 to 1.8.
Okay, Dr. Kannan, is this dose of atorvastatin 80 milligram too high?
We need to use high-dose statins in patients who present with acute coronary syndrome. We are guided in this by the results of the Miracle study, where they compared atorvastatin 80 milligrams with placebo, and the Prove It trial, where they compared atorvastatin 80 milligrams with pravastatin 40 milligrams. In both these trials, the use of high-dose statins reduced MACE rates as compared to using lower-dose statins. It is believed that the pleiotropic effects of statins, which bring about things like anti-inflammatory effects, benefit to the endothelium, placating the plaque, even before reduction of LDL cholesterol brings about these benefits. In the sub-study of Prove It, TIMI-22, which was named the PCI Prove It trial, in patients who underwent PCI, use of high-dose statins reduced subsequent events.
Okay. Yeah, this is just a summary of what he said, that if you want to see regression, you have to bring your LDL right down. And it's interesting that as compared to patients who had stable angina, patients who had acute coronary syndromes had more regression. So in this group of patients, you want to hit them hard and keep the LDL right down because they have the greatest benefit. Now, Dr. Chan, this patient's liver enzymes are raised. Is this a contraindication to statin therapy?
The answer is that no, it's not a contraindication to statin therapy. However, we need to find out why the enzymes are elevated. It's important to exclude perhaps whether or not he's got chronic hepatitis B, or that he's been taking any therapies that might have disturbed the liver function. But if you have excluded it, and in most times, these individuals with moderately or mildly raised liver enzymes is because of fatty liver. And fatty liver is not a contraindication to use of statin therapy.
Dr. Chan, what if this man is hepatitis B positive? Will that be a contraindication to statin therapy?
Then you need to have a sort of like specific liver gastroenterology assessment to see whether or not this patient is having an active hepatitis. So they will need to go and have a appropriate hepatitis assessment before you deem whether or not the patient can take statin therapy.
Okay, thank you. Dr. Kannan, this man is not on any anti-ischemic medications and discharge. We have learned that patients with coronary artery disease must be on beta blockers, must be on ACE. Why do you think he was not on anything?
This patient had a single lesion which was fixed with angioplasty. All his other arteries are said to be normal, so he has got no residual ischemia. So there's no reason to give him a beta blocker which may have its own side effects. His LV function is also reported as normal. There's also no need to give this patient ACE inhibitors because his blood pressure is well within normal and his left ventricular function is also good. This would have been two indications to give him ACE inhibitors otherwise. It could be argued that ACE inhibitors have got beneficial effects on the vascular endothelium, and for that reason, one could give ACE inhibitors in patients with coronary artery disease.
Okay, thank you, Dr. Kannan. Now, moving on, patient 2 months later, he comes for review. He is very well, he's exercising regularly, BP is as shown, and his latest lipid profiles are as shown. Total cholesterol 2 with the LDL of 0.8. So the first question and the next question are both directed to Dr. Kannan. Are you going to change your management, and is the LDL cholesterol too low?
Though there are those who would say that the lower the LDL cholesterol, the better, I would personally decrease the atorvastatin from 80 milligrams to 40 milligrams because there are studies to show that the higher the dose of the statin, the higher the side effects. I would allow the LDL cholesterol to float up to between 1.4 to 1.8, which is the current recommendations. In a meta-analysis which was published in Biomedical Central, which came out in August of this year, this involved more than 26,000 patients. The meta-analysis showed that high-dose statins reduce MACE rates but increase adverse events. In this meta-analysis, it was mainly directed at myalgia and myopathy, as well as elevation liver enzymes, 4.99% in high-dose statin group versus 2.98% in patients with relatively lower statin therapy.
Dr. Kannan, I ask again, suppose this man had this sort of lipid values with just an atorvastatin dose of 20 milligrams. Will you then cut it down, or are you quite happy to continue at atorvastatin 20?
Will continue at atorvastatin 20 because some of the earlier guidelines also told us that besides the numbers that we look at LDL cholesterol, the dose of the statin is also important. That if the dose of statin was not adequate, even though the numbers are better, it might not be effective.
Okay, thank you. The other questions I'm always plagued by, since this man's cholesterols are required for growth, hormones, etc., will it affect his sexual function, Dr. S.P. Chan?
Okay, that's a very good question. Well, this guy is an adult, so therefore I do not have to worry about his growth, right? With regards to hormones as well as sexual function, there have been no definitive data, especially in those prospectively done trials on high-dose statins as well as the latest PCSK9 inhibitor, which drive the cholesterol really, really down, has not been associated with worsening of sexual function, no worsening of erectile dysfunction. And in fact, some of the prospectively driven trials suggest that sexual function improves when these individuals are on statins as well as PCSK9 inhibitor. So the answer is no. Therapy with statins as well as PCSK9 driving the LDL right down does not adversely impact ED. Of course, I'm sure you have heard from individual patients who will come back and say, you know, when I take your medicine, it does this. But the large-scale studies have not proven this.
Yes. Sexual dysfunction is multifactorial, and unfortunately, there are a lot of anxiety, stress levels can also affect it. So it's difficult to explain to the patient it's not due to the medication. Again, the next question to you, SP, is are you happy with his fasting glucose level and would you want to do anything further?
Well, the answer is, of course, I'm not happy with the fasting glucose. This guy has a fasting of 5.7. That puts him in the pre-diabetic range. Fasting glucose of anything above 5.6 to less than 7 is a pre-diabetic range of fasting glucose. He's had what appears to be an event of a person with metabolic syndrome. So I certainly need to, as you say in your earlier statement, categorize this man with regards to his glucose tolerance status, right? So that would suggest that I need at least an A1C. And if the A1C shows between 5.7 to 6.5, this patient is in a pre-diabetic A1C range. And it depends on family history. If there's a very strong family history of diabetes, I may even go on to do an oral glucose tolerance test.
Okay. Thank you very much, SP. Now, what is the connection between statins and cerebral bleeds, Dr. Yong? Because this is another thing which worries patients a lot.
Early this century, in the 2000s, there was this Sparkle trial, stroke prevention by aggressive reduction in cholesterol levels, and the heart protection study, which suggested that the use of statins may increase the risk of intracerebral hemorrhage in individuals with a history of stroke, particularly in those with prior intracranial hemorrhage. But subsequent observational studies have disputed these findings. Still ongoing, there are a lot of prejudice against using statins for the fear of increasing the intracranial hemorrhage. Now, the latest study does not support this, and I quote to you this study, which was published in Stroke this year, Statins and Risk of Intracerebral Hemorrhage in Individuals with a History of Stroke. This is done by using the Danish National Registry, a population-based propensity score match cohort study, and they're using large numbers as compared to the previous studies. They had intracerebral hemorrhage numbering 2,728 and patients with ischemic stroke numbering 52,000 and more, and they followed up for up to 10 years. They were compared with the propensity score. And the result is that in patients with prior intracerebral hemorrhage, the statin use does not increase the risk of further bleed. And in those with ischemic stroke, of which the majority are, it can reduce the incidence by up to half. It suggests that ischemic stroke using statins reduce the incidence of intracranial hemorrhage. So the answer is statins do not increase the risk of intracerebral hemorrhage, even in those who had prior bleed.
That is very, very reassuring, Dr. Yong. Okay, moving on to now, this man, as most of our patients are, is lost to follow-up. And he turns up after 3 years. He's still well, walking around. He's on cardioprin, and he, reduced it on his own to his atorvastatin 10 milligram because this is what his next door neighbor told him to. His cholesterols are as showed. His LDL is now 2.5, and this is his sugar and his HbA1c. Okay, Dr. Kannan, are you happy with these levels?
I'm certainly not happy with these levels. Although he is stable, he has got established coronary artery disease. His atherosclerotic disease may progress with time. We have seen this time and again in patients who have been lackadaisical with their treatment. We must talk to him and advise that he increase the dose of his statins to keep his LDL cholesterol between 1.4 to 1.8 millimoles.
Okay, thank you, Dr. Kannan. So, SP, what is the association between statins and diabetes, SP?
If I could show you the next slide, it is a meta-analysis of large number of trials, and you can see from that meta-analysis, 91,000 participants, 13 trials, and you can see there is a 9% increase in risk of developing diabetes if they are not diabetic at the time the statin was initiated. However, you can see that when they calculated the risk, for every one new case of diabetes, you prevent 5 cases of cardiovascular events, including death. So out of 255 patients treated for 4 years, you get 1 new case of diabetes, and you have decreased their chances of dying or having a recurrent cardiovascular event by 5 events. So there is absolutely no contraindication, should not stop statin just in case this patient has a higher risk of developing diabetes, like this gentleman who's got an impaired fasting glucose level as well as an impaired A1C. The benefit of reducing MACE events far outweighs the risk of developing diabetes.
Dr. SP, is there any particular predisposition of the patient which will make him more likely to develop diabetes?
Well, we all know the data for that. I mean, we are familiar with the genetic risk. If the patient, the entire family is diabetic, just waiting for him to kena, all right, of course, that puts him at a very high risk. If he also has all the other parameters of metabolic syndrome, like hypertension, he's big with a large belly, all these things will make him at higher risk of developing diabetes. However, as Dr. Kannan has emphasized, he's got established cardiovascular disease. He must be on the statin. Otherwise, the risk of him having another myocardial infarction will be much higher than for him to develop diabetes, and should not be, how would I say, a reason for not giving statins.
Okay, Dr. Yong, the other reason why he cut down his dose of statin was because he was worried it would cause dementia. Is this correct?
Again, that early this century, there were a lot of case reports saying that after patients were started on statin, they had cognitive impairment. Now, this is very related to the onset of starting the statin, and it's not causing dementia, but reversible temporary cognitive impairment. So if a person who has been started on a statin feels that his memory is worse and he can't think as well, then perhaps they should cut it down or not take it. But if we are talking about dementia, the answer is absolutely not true. And I again quote you this large study extracted from Neuroepidemiology, published this year. And they studied the population-based patients from Canada, 90 million of them, 85,000 of whom had dementia. And it's a total of 30 observational studies, and they did a meta-analysis and found that patients with statin had a lower risk of all-cause dementia than those without statin. And the overall reduction in Alzheimer's disease is, the relative risk reduction is 0.69. So the conclusion suggests that the use of statin is significantly associated with a decreased risk of dementia.
That is very good. You should actually take it to prevent dementia.
I'm not sure whether it should be done. They do not support that. No, they also said is that until further evidence is established, clinicians need to make sure the statin use should remain restricted to the treatment of cardiovascular disease, not to prevent dementia. Those are done by other means.
Thank you very much, Dr. Yong. Okay, going on. He was also very worried regards his kidneys. That's why he cut down his dose. Dr. SP, is that a correct observation?
Absolutely correct. I don't have anything else to say. There's been absolutely no correlation between statin and renal impairment, renal dysfunction. So that's
Okay.
absolutely wrong.
Yeah, but I think that in the early studies, rosuvastatin was associated with some tubular proteinuria that when you stop it, it goes away, but the creatinine was not affected because it was not at glomerular level. Okay, so some take-home messages. After an acute coronary event, high-intensity statin should be initiated to achieve an LDL as low as possible, at least less than 1.8, preferably less than 1.4. Even for stable coronary artery disease, the target should be less than 1.5, preferably less than 1.4. And high-intensity statins are those as shown there. And these are generally safe, except for occasional muscle aches. But just don't look at lipids, look at other risk factors, which all should be treated to target. Moving on to case 2. A 30-year-old man, quite young, is referred to you for diabetes. He is slightly overweight. That his BMI is 28.2, blood pressure 140/80. His mother has diabetes at 40 years, and he is the eldest in the family. His sugar, he was 11 millimoles, HbA1c 7.8, and his lipids are as shown. So the first question to diabetes, how would you treat his diabetes, and what is your first choice of oral hypoglycemic agent?
Right. Just to remind everybody, BMI of 28 renders him in the obese category, according to the Asia Pacific guideline. Anything above 27.5 is obese, unfortunately, because for Asians, we developed all the metabolic problems at a lower BMI. So it depends on what level target A1C we want to aim at. Very young men, newly diagnosed, no complications that we are aware of, we should drive his A1C down to 6.5 and lower, right? So since he is about 1.3% higher than the target, the recommendations suggest that you should be considering 2 oral agents at the outset so that you can actually drive the A1C down more successfully from the word go. So it would include, because his BMI is 28, metformin, which is well established in terms of its safety and efficacy in patients with type 2 who are insulin resistant. And on top of that, an additional oral, which can be depending on the circumstances of this patient. If his BMI is 28, it may be an SGLT2 because you want to try and get him to lose some weight as well. Or if he says, look, doc, I can't afford the new expensive medications, then perhaps he may require some sulfonylurea or a DPP-4 inhibitor. So the answer, Dr. Jaya, is probably requires 2 agents to drive him down to 6.5 as quickly as possible. But if he tells you, look, doc, I haven't been following any diet at all, and now my A1C looks like this, then perhaps you can try with 1. But if he says, I knew I was going to get it, I've been on a diet already, and still I'm diabetic like this, you may want to go for 2 at the first onset. Okay.
Okay, thanks, SP. Okay, would you prescribe a statin, SP?
You're asking me? Okay.
Yes.
The recommendation is that if there is no indication, any adult below the age of 40 with type 2 diabetes does not require a statin.
Okay, so
There may be some instances where you might consider it if he's had a long-standing duration of diabetes of longer than 10 years, or there are high risk family history. But if he is otherwise very well, no endothelial dysfunction, no microalbuminuria, then there is the guidelines suggest that you do not require statin until they are above the age of 40.
Okay, you want to share this slide? Not yet.
Okay, here the slide shows the efficacy of reducing cardiovascular events, and I think all of you would have seen this presented by many people. So that blue line where you see the laser pointer going up is the secondary prevention line. So the x-axis is LDL cholesterol, and you can see the event rates in patients who have had established cardiovascular events. All right, and then the yellow line are the trials where patients are primary prevention. Okay, now if I just show you, this is the event rates with diabetes. It should come up. There should be a red line that comes up. Aha, here we go. Right, this is the event rates for primary prevention trials in diabetic individuals. And you can clearly identify that these patients who are diabetic without established events have event rates close to secondary prevention individuals in the general population. So this is just to recognize the high risk for events in patients with type 2 diabetes, even though they may not have developed events at the point that you are managing them.
Okay, now he's worried about his heart. He's only 30 years old. So SP, he's asking you, what would you do, SP?
Well, as I said, the guidelines suggest does not require me to even do any cardiac assessment. But then the conversation will be whether or not he has got a very strong family history of young ischemic heart disease or young sudden death. If that's the case, as well as perhaps he's had diabetes for a long duration, as I said, diabetes duration beyond 10 years is considered a cardiovascular risk equivalent. So if he's got a very strong family history as well as perhaps microalbuminuria, then yes, I will investigate his heart, his cardiovascular status. But if not, then I will not do beyond just a simple baseline ECG. I do know that maybe Dr. Kannan has a different opinion.
Yes, Dr. Kannan, would you want to say anything?
I certainly would. I mean, we have seen many young people, especially in our Asian countries, especially those Indians. And seeing someone in their 30s to 35-year range coming with a myocardial infarction these days is no longer a rarity. So, I mean, I would evaluate him. He obviously needs a good history and a clinical examination. In addition, I would certainly want to do at least a baseline ECG and a chest X-ray. And in most of my patients, I would do a treadmill test as well. Because if nothing else, this provides me with a baseline. This patient is probably going to see me for the next 10 to 20 years. And if things change, I'll be able to be on top of him.
Pressure 140/80. Huh? Okay, sorry. Thank you very much for your answers. Now, what about the blood pressure? SP, are you happy with this blood pressure 140/80?
Okay, 140/80 is not acceptable for this man of 30. All right. Again, we don't rely on one measurement in order to decide how to manage the blood pressure. The recommendations, the guidelines suggest that you should do at least a second reading at a different clinic visit. And if it's still elevated, then he may require antihypertensive therapy. There have been some changes to recommendations for initiation of blood pressure medication. And that is an individual with a blood pressure above systolic 140 and above diastolic 90, then these individuals require antihypertensive therapy. But on 2 occasions, above 140, above 90, either one, the individual should be given antihypertensive therapy. This guy is 30 years old. BMI is 28, not that big. So again, you need to also investigate why he might be hypertensive at this young age.
Okay, thank you. Kanan, is there a role for CT coronary angiogram in this man?
Could I also answer the bit about the blood pressure, my take on it?
Sure.
Okay. I mean, I agree with all the things that SP has said. This man is diabetic. I think the guidelines tell us that in diabetics, we ought to be stricter with the blood pressure control. We should aim for 130 and below systolic, and certainly the diastolic is below 85. Now, I agree with the other things that SP has said, but I would say that in this man, all of us would, as a first step before we introduce pharmacotherapy, would advise him about lifestyle measures, which will be, although he's not that overweight, we want him to lose some weight, we want him to exercise regularly, and then monitor his blood pressure before we do more. I think your question is about the CT angiogram. At this point in time, if there are no other risk factors except for diabetes alone in a 30-year-old man, there's no role for CT angiography.
Thank you, Dr.
Comes up with sugar of 8 and HbA1c of 7.8, and that is his level. Is his sugar control acceptable, and what about his lipids, SP?
Okay, I do not know whether he's been started on therapy for his diabetes. If he is only on diet, this still renders him far off his target A1C. Again, reiterating that this is a very young man, uncomplicated, so therefore should drive his A1C down to 6.5%. So my earlier comments hold true. I do recognize, and I'm glad that Kanan reminded me, lifestyle intervention is still exceptionally important in this gentleman whose BMI is 28. So maintain the lifestyle modification that you are continuing to remind them. But you would definitely initiate glucose lowering therapy at this instance if not already done. Please remember this is 1 month later, so we don't expect the A1C to have changed very much. So I would still drive a lot of the commentary to trying to improve his A1C as well as his fasting. For a person, the fasting glucose should be less than 7 millimoles. For his LDL, the answer is it does not require any lipid lowering therapy at this moment unless there are cardiovascular concerns.
Thank you, SP. Now, after digging, he says that his maternal cousins, 2 of them, had coronary artery disease and required stenting, and both were in their 30s and early 40s. Will you change your management, SP?
Well, then the answer is yes. If he comes with a very poor family history like this, certainly he would require very detailed cardiovascular assessment for sure.
So will you do a CT coronary angiogram in this man, Dr. Kanan?
I think he has now earned a CT angiogram because there's a family history of premature coronary artery disease, in fact, very premature coronary artery disease. The CT angiogram is going to be helpful. One of the things we must remind ourselves is that in young people, if we see plaques, they're going to be non-calcified plaques. So our usual calcium score might even be 0 in this group. But if we can demonstrate plaques, which we certainly can with the CT angiogram, then treatment has to be very aggressive. First step again is lifestyle, very strict control of his diabetes, and then the introduction of statins to bring his LDL cholesterol down to 1.4 to 1.8.
Thank you, Dr. Kanan. Okay, just some take-home messages. In a young, less than 40-year-old diabetic, statins are not routinely given unless the LDL is very high or they have other associated severe risk factors such as hypertension, smoking, or there's endothelial damage such as proteinuria or a positive family history of premature coronary vascular disease as our young men. CV assessment has to be individualized. Moving on to case 3, 65-year-old woman, diabetes for 4 years. She's actually quite well, exercises regularly. All her siblings have diabetes, and her eldest sister had a stroke at 68 years. She is a bit overweight too, and she is on diamacron MR, metformin, simvastatin, and amlodipine. And these are her fasting sugar, HbA1c, and her lipid profile. SP first, are you satisfied with her diabetic lipid control?
With regards to her diabetes control, her A1C is 7.2%. It is above the target that we want, and so the answer is no. I'm not satisfied with her glucose control. I would obviously try and convince her to initiate another glucose lowering agent. It does not have to be insulin. She's only about 0.2, or even if you want to drive her down to 6.5, she's only about 0.7% above target. So depending on, again, her cardiovascular risk status, if she is at high cardiovascular risk, like having microalbuminuria, other, as she said, her elder sister had CVA, I might be willing to consider an SGLT2 inhibitor for her, because as you said, the BMI is 26, and it is above the optimal BMI that we want for her. So yes, I would initiate a third agent to try and drive down this A1C. The lipid levels, according to the guidelines, the LDL is less than 2.6, but the recent guidelines suggest that type 2 diabetes, for primary prevention, we should be driving the LDL down to 1.8. So according to the current guidelines, we should be escalating the statin therapy, or perhaps changing to a more potent statin.
Okay, thank you. Now, in view of the family history of stroke, she's worried. Dr. Yong, she comes to see you. What would you advise?
I think this lady who is postmenopausal with a history of diabetes, primary prevention with antiplatelet is a reasonable choice. So I would put her on an antiplatelet aspirin. It is recommended in guidelines, especially for postmenopausal women who have diabetes. These are the only group that would benefit from primary prevention with aspirin.
Yes, SP, you want to say something?
Yes,
Sorry, the guidelines don't suggest that, Young, because the data with regards to antiplatelet therapy for primary prevention in type 2 diabetes, it's sort of a controversial topic. The data suggests, I can't remember the name of the trial, that yes, you can prevent events, ischemic events, but the risk of bleeding from the antiplatelet therapy is higher than that benefit. And so the current recommendation as it stands is that she should not be given antiplatelet therapy. But if she has a very high risk, she has got microalbuminuria and other evidence of endothelial dysfunction short of an event, then you might consider antiplatelet. I'm just talking about the guidelines.
I think it has to be
Individualized. But I agree with Dr. Yong that because she has a stroke, yes, Dr. Yong, you want to say something?
No, I mean, SP, I don't know whether you are differentiating between male and females. They do not recommend it in men because the risk of complications is higher because they're more at-risk behavior. But in women, I think it is suggested that they can try in order to prevent.
Yeah, I guess we all need a lot of clinical judgment. I mean, this lady has got a sister and she's worried. Well, that was the next question, which we can skip now. Now, So they decided not to take the aspirin because the SP said don't take. About 4 months later, she gets admitted to the middle of the night with sudden weakness of the left side of her body for about an hour. A CT brain was done within 30 minutes and it was normal. So Dr. Yong, what would you do?
I would rush to hospital, and if there's no contraindication, I would thrombolyze her straight away. I would give her TPA. Yes.
Okay, so Dr. Yong gave her TPA, and then the next day, when MRI brain was done, and it showed a lacunar infarct in the thalamus. The MRA showed no intra or extra cerebral vascular lesion. Why did this happen, and how would you manage? Dr. Yong.
Having diabetes does increase your risk of small vessel as well as large vessel disease, especially in small vessel disease. So the fact that she had diabetes put her at risk of having an lacunar infarct. And even though it was not a large vessel disease like a middle cerebral artery, she would still do better with thrombolysis. Studies have shown that those who have thrombolysis for so-called minor stroke do better than those who do without. So the treatment would have been
and
safe.
you would have given the aspirin earlier if she had seen you.
Well, I don't want to.
Okay, some take-home messages. In diabetics, more than 40 years of age, statin should be routinely prescribed. Target LDL-C is less than 2.6, although the latest guidelines say it should be less than 1.8. If they have associated cardiovascular disease or proteinuria, less than 1.8, preferably less than 1.4. Now, the other thing that we didn't comment is that the patient had low HDL and high TG have been shown in epidemiological studies to be CV prognostic indicators. The main management is non-pharmacological measures. The reason is because most of the medications do have side effects which tend to negate some of the benefits seen. Subgroup analysis of the ACCORD seem to indicate fibrates, lower TG, raised HDL, and maybe of some benefit. The role of fish oils, we shall talk about later. Moving on to case 4, we don't have much time, but we will talk about it, is a 56-year-old man, asymptomatic, came for a medical examination, no illnesses, slightly overweight, 26.3, BP very good, very happy with his sugar, but that's his cholesterol levels. Now, you put him in this Framingham risk card, and you put his age, HDL, triglyceride, total cholesterol, blood pressure. He doesn't have diabetes, and he comes up with a 10-year risk score of 13, and gives a 10-year CV risk of 15.6. So he's moderate, and according to the guidelines, his LDL should be less than 3 because it's a moderate risk. Okay. Now, these are different scenarios. Okay, what is the target LDL? Sorry, I shouldn't have opened my mouth. Target LDL, and would you start statin therapy in these different scenarios? First, Dr. Kannan. His father had cabbage at 65 years. This man had already done a calcium score, and his CT coronary angios were normal. Would you start a statin on him?
Okay, this man has got clean coronary arteries by CT angiography. As we have assessed him, he belongs to moderate risk group. His BMI, as you have pointed out, is slightly above normal at 26.3. So I would not start him on treatment straight away. What he needs is lifestyle advice. He has to lose some weight. He has to exercise regularly. Then I'll bring him back probably in about 3 months, reassess his lipids, and then make a decision at that time. If his lipids still remain at more than 3.4, then we'll have a little discussion with him. We'll talk about statin therapy. We'll talk about benefits versus adverse events. And if he's amenable to therapy, then we'll start him on statins and aim to bring the LDL down.
Now, second scenario, a little bit different, same thing. His sugar is now 6. HbA1c is 6.2. Mother had a CVA at 78 years. Father at 80 years. His calcium score is as shown, and the CT coronary showed a calcified plaque. Okay, this is a calcified plaque. This is CT coronary, but it is not causing any significant luminal narrowing. Dr. S.P. Chan, what is your advice to this man? Should he start a statin, and what is his target?
This gentleman obviously has pre-diabetes, as shown by the elevated fasting as well as the elevated A1C 6.2%. So that already in the pre-diabetic state renders it at higher risk of developing cardiovascular disease above and beyond a non-diabetic individual. Despite the fact that he has calcified plaques and no significant luminal narrowing, he should really consider taking a statin and lowering that LDL cholesterol down, because he is, I think if you calculate his score, I don't know, it might actually end up being a bit higher, I think, his cardiovascular, I mean. So again, let me just repeat, he has pre-diabetes. Pre-diabetic state makes that individual intermediate cardiovascular risk from overt diabetes and a normal population. Although I must admit that his parents didn't have early premature ischemic events, he's still considered as higher risk than normal. So I would probably move for statin therapy, Kanan.
Dr. Kanan, his calcium score is 13 and there's no luminal narrowing. What would you start a statin, and what would you try and aim for?
So if we calculate his risk score, it has now moved to 16 because he's pre-diabetic. So his 10-year risk has now come up to 25%. Now, CT angiography is not included in the risk score assessment, but this is something I'm sure is going to be added in time to come. So if you look at him, if you look at his CT angiogram, this man already has established coronary artery disease. So it actually puts him to the very high risk category. He certainly requires statins, and he must receive adequate statins to bring his LDL cholesterol down to 1.4 to 1.8 to try to prevent future events.
Thank you. So I guess this is now his sugar is 6.3, 5.9. This next scenario, and calcium score is this as shown. So I guess both of you would agree that you would start a statin and you're trying to keep his LDL less than 1.4. Kanan and SP both agree for this scenario? Okay, all right. Now, the last that we'll talk about a little bit is what is the role, if any, of PCSK9 and ezetimibe. Kanan, you want to take about PCSK9? What is the role, if any, of PCSK9 inhibitors and ezetimibe?
I think at this point in time, the role of PCSK9 would be to use in individuals who are at high risk of vascular disease, whose LDL cholesterol has not been brought down to guideline levels with the use of statins and drugs like ezetimibe. Then you would introduce PCSK9. Having said that, PCSK9 is quite an expensive drug to use, but in the high-risk patients, it has been shown to be beneficial.
Okay, ezetimibe is something that a lot of us use, and in combination with statins, it can cause an LDL reduction of a further LDL reduction of about 22 to 23%. Although by itself, it is a rather weak LDL lowering agent, just causes about 17%. So we hardly use ezetimibe by itself. A lot of us are also asked about fish oils. Now, fish oils, people, as I mentioned earlier, they can use it to either reduce TG, but this table shows that if you want to reduce your triglyceride by 25 to 45%, you need to take, depending on which one you're using, anything from 4 tablets to 13 tablets a day, which of course by itself, there's also a lot of calories, which may also make him put on weight. What about CV benefits? Now, these are recent trials, which was most of it negative or neutral trial. In this year, SN was slightly earlier. Vital was slightly earlier, the last 3-4 years. These were neutral trials. They did not confer any CV benefit. The one which was presented in AHA this year is a strength trial, and the Omemi trial, again, neutral for cardiovascular benefit. The only one which was positive was this reduced IT trial and the JELIS trial, where they used a preparation of called icosapentadyl ethyl EPA, and those were the only positive. There's, you can sit and fight, is it really, what was the difference between these two trials? But right now the jury is out. It appears that omega fish oils do not really help very much for cardiovascular reduction. Lecithin, very little information about lecithin for cardiovascular prevention. Virgin coconut oil, there's not enough data about the use of virgin coconut oil for cardiovascular prevention, although the layman will tell you it's good for the heart, but scientifically, no randomized controlled trial which shows that virgin coconut oil has cardiovascular benefits. And lastly, for oats, depends upon how much you use, and yes, there is a very modest 4.2% reduction in LDL, and it again depends on whether it's liquid, how much you take, whether it's refined, not refined. Exercise, good, but it only improves your HDL and reduces TG. Not many effects on LDL. So these are the take-home messages. Treat LDL to target, determine the LDL individual's LDL target, and these are the expected LDL reduction with dietary modification, statins, depending on drug and dose, ezetimibe, PCSK9 can really reduce it. And in managing combined hyperlipidemia, the primary goal is still achieving LDL-C to target. And for treating low HDL, high TG, options include, first option, non-pharmacological therapy. Second, optimize diabetic control. And if levels are not achieved, consider statins alone first, and then, if necessary, the addition of fibrates. Statins are one of the most effective, cheap, and safest methods for reducing LDL levels. Yes, they do have some side effects, but these are very, very small as compared to the benefits. So on behalf of my panelists, Dr. Chan, Dr. Yong, and Dr. Kannan, I would like to thank all of them. I would like to thank Dr. Kannan, and lastly, and most importantly, I would like to thank Kelly and all of you for listening in. And very important, Dr. Allen, do not forget the QR code. Oh, there's a Q&A. All right, okay. He is going to show the Q&A. The questions.
The first question at the bottom, we start with the earlier one. Prof. Kannan, what about J-curve with increased mortality when LDL is too low? We can maximize the screen.
Can't see it. What is it?
Is there a J curve?
I'm not aware of the J curve.
J-curve with increased mortality and LDL is too low.
I'm not aware of that. Are you aware?
Some epidemiological data, prospective studies. I know one of these is the Korean registry, which they just published this year, and there were some other registries that may be with low. These are very healthy people, and they say that the HDL is too low, total cholesterol is too low, it may be associated with increased mortality. But again, these are epidemiological studies. You have to be very careful when you analyze it, because this it is possible that there were many other confounding factors. The total cholesterol may be low because of their lifestyle, maybe because they are sick, etc. So you have to take it with a pinch of salt. Anyway, the guidelines are for people with established cardiovascular disease, established diabetes. Yes, the SP, you wanted to say something?
There is no J curve for LDL. I think from all the data, we know that from the LDL hypothesis, the lower the LDL, the better the protection, especially from the latest PCSK9 inhibitor treatment, you know you can drive the LDL down to almost zero. And this is what I'm hearing from my cardiology colleagues, that when there's patients who are vascular pads are on PCSK9, your LDL is down to like 0.3 or 0.5. There is no association with increasing mortality if used for vascular prevention and event reduction. What Jaya is mentioning is correct in the sense that there is probably a multifactorial reason why LDL, when it is low, that there is an increasing mortality. Probably these individuals are ill, they are sick, they are emaciated, and perhaps one of the common causes for low cholesterols and LDL in particular is when they have malignancies. So it's probably that is driving that weird suggestion that LDL is too low. LDL increases mortality.
There's a question from Dr. Casey Nair. A physician once said the only anti-diabetic drug recommended is dapagliflozin as it presents or delays dialysis, heart failure, and renal impairment. True?
False.
Rubbish. All right. So I don't know which physician is talking crap. Diabetes is caused by hyperglycemia. There are multifactorial reasons why they are hyperglycemic. Everybody knows about the pathophysiology, insulin resistance, beta cell defect, incretin defect, and all the other things that contribute to hyperglycemia. All right. If you give only an SGLT2, and this physician is incredible. Just only DAPA of all the SGLT2s is given. You don't address the insulin resistance. You don't address the insulin secretory defect. You may never get glucose control. Please remember, you don't live by heart failure alone. You get retinopathy and turn blind. You get amputations because of gangrene. Have you forgotten that? Please don't be so, gullible to listen to this kind of lopsided discussions. Sorry, very passionate about this problem.
All right, that was definitely passionate. There's one question from Dr. Sudhakar. What about statins in diabetic patients with liver fibrosis, which has reduced liver enzymes and on Heptrel? Just say AST/ALT 100, 120, do we initiate statins?
Sorry, I didn't catch that. What about statin in patients with liver fibrosis? Okay, I think you need to get the appropriate assessment of the patient's liver status. And if the patient has such severe hepatic impairment, then we do not know about the problem of what that person's life expectancy is going to be like just because of that poor liver functional status. But having said that, we do know that you can still use statins for prevention of vascular events in patients with diabetes, even when you have liver enzymes that are elevated. But if they have active hepatitis, then probably it would be safer for them to get that sorted out before the statin issue or discussion on starting statins come up.
It's a question for Dr. Kannan. Can Dr. Kannan comment on high HDL? I read that a very high HDL is not good.
I think the answer to that is that people now realize that HDL subfractions, there are many. You can have 1, 2, 3, 4 subfractions, and you can have so-called bad HDL levels. So I think it is not someone having very high HDL that's bad. You may have people, generally speaking, those who have got high HDL levels have got some protection against vascular disease. But some patients with high HDL levels may have dysfunctional HDL, so they do not have protection. I think that's the answer to that. But these the subfractions have been measured in a dedicated lab, and generally we do not do this.
And I have a question about red yeast rice because that's what some of our patients are taking for high cholesterol.
I can
Comments?
answer that.
Alan?
Okay.
You get red yeast rice. You have use monocolin or something. Okay, first of all, it's a fungus that is put on this red yeast, and it's supposed to come up with a product called monocolin, which is very similar to lovastatin. Yes, it does cause your cholesterol to come down a little bit. Number one. Number two, when you buy a red yeast off the counter, you must look very carefully because different supplements may have different amounts of monocolin. So it just doesn't mean that if you're buying red yeast supplement A, you're going to have the same amount of LDL reduction as another supplement which is marketed as B. So you must look at the amount. Number three is that you do not get the same amount. For example, we say you take simvastatin 20, you get a 30% reduction in your LDL. We cannot say that for this. And number four, you cannot get an LDL reduction by just taking one pill because the amount it contains of monocolin is 0.05%, really very minuscule. So you have to take quite a number of this. You don't expect one pill and cause an LDL reduction. And last but most importantly, in the preparation, when they put this fungus to make the red yeast rice, you also get other products such as citrulline. And citrulline can be toxic to your liver and kidney. So if your luck is bad, you buy a supplement which has got lots of citrulline, you not only get your LDL down, your kidneys also go. Yes.
Time is one more question. Okay, there are two more questions. We are right for three more questions.
All right.
Dr. How to handle any phobia in YouTube? With some speakers claiming to be eminent doctors.
Sorry, I didn't hear that.
Okay, basically the question was in YouTube, you hear a lot of people saying negative things about statins and how they affect their memory and stuff like that. I think there's really no way that we can handle all this negative social media. The only things that we can do is we can talk to our patients, provide them with the proper information. In fact, very recently in the AHA, they presented something, the Samson trial. And what they did was, this was done in Canada, they actually took a group of people, they gave them statins, and then they put them on a placebo after a period of time, and then they reintroduced the statins. And they found that even when they were on placebo, 90% of the patients still had the same side effects that they complained about when they were on the statin. They call this the Nocebo effect. And basically what they're trying to say is, yes, some of the side effects which the patients complain are real, but even patients on placebo, when they were on placebo, they also have the same side effects. But if you reintroduce the statins, 50% of them were able to take on the statins. So really, we cannot really handle all this YouTube and negative social media.
Thanks, Dr. Jaya. I think it's just countering with education for doctors and public alike. I think just last question, I think directed to SP, how to manage dawn effect with normal HbA1c.
That's a difficult question to answer. You're talking about patients whose glucose rises as they wake up. That dawn effect is just a excessive response to the increase in our hormones to enable us to wake up to start the day. So when our cortisols go up, our catecholamines go up, the glucose goes up as well. So if the patient has a normal A1C, I'll just reassure the patient, generally your overall glycemic levels are in order and therefore does not really require anything else. Some options are to give metformin XR, the long-acting glucophage or metformin that will reduce hepatic glucose output through the night. Some, if success, but not in all patients. But if the A1C is normal, I wouldn't be too worried about the patient.
Okay. I think time is up. There are generally a lot of good feedback from our viewers. Dr. Lim says thank you, good discussion, and some other Facebook users actually found it to be a very good talk, very good session. So I think we just have to be clear, the QR code shown there is not the one for points, it's for the Slido. So I will actually now come and show you guys the real QR code for points. We won't forget this time, sorry. Yeah, anyway. So to claim the code, and the moment you're waiting for is this is the QR code. Let's see if it works, yeah.
Yeah, speaker, I will do it for you manually.
If you can, was it successful?
This is okay.
Okay.
When you scan something, capture.
Yeah.
That is already not. Okay.
Yeah.
No, I can do it manually for speaker and delegate.
Yeah.
I have not done my scan nothing yet.
Okay.
Yeah, I think.
Have a good weekend.
Okay, so finito.
Finito. So thank you, everyone.
Thank you very much, Ellen.
Yeah,
Thanks
yeah.
a lot.
Are we offline?
Not yet. We are still online. I'm going to go offline now. The code will still be there. You can replay the video. I think it will be still valid for another 15-30 more minutes. So I hope that people saying QR successful. So have a good weekend, everybody. Thank you for the panel for the excellent talk. I learned a lot again. Forgot a lot of things about cholesterol. Okay. Bye-bye.